I'm here at the International Continence Society and IUGA meeting with Dr. Christine Whitmore. One of the things that you were talking about in the seminar here was severe IC, and that there was controversy still on how to treat it. At the last AUA meeting, we heard a talk about very severe IC, patients with very small, hard bladders, usually Hunner's ulcers, terrible pain, and whose disease went very fast. And the conclusion seemed to be that they needed to have their bladders removed. What's your experience?
Well, in a patient with severe symptoms, there's usually someone who's had symptoms for more than 2 years. So hopefully in the future we'll be able to get everybody in with less than 2 years duration of symptoms and be able to treat them easily. However, about 5% of patients have an end-stage IC. Their bladder capacity under anesthesia is less than 350 cc's. They have Hunner's ulcers or lesions. They have severe symptoms. They're refractory to 5, 10, 15 types of treatment. All right, what do we do with this patient? First rescue would be intravenous or intravesical therapy. We can go by the AUA guidelines, which are suggesting the trial of cyclosporin A. That should be done with the help of a rheumatologist because it can affect the immune system. In those patients who have Hunner's lesions or ulcers, the lesions and ulcers can be lasered, fulgurated, or injected with steroids. The level of evidence for that treatment and the new AUA IC guidelines high. And patients can have Botox injected into the bladder, although that's off-label. And another off-label treatment that can be tried is sacral neuromodulation. And I don't think anybody should be subjected to major surgery until they fail all of those things.
Injecting steroids into the Hunner's lesions is kind of a new thing.
Actually, it's not. It's an old thing. It's just that the small number of studies were conducted well, and the symptom improvement was pretty dramatic. That's why it's included in the guidelines. And certainly, it's not very invasive if you're looking in the bladder. So more recent studies, and we're going to do this at our institution as well, will be to prospectively study symptom severity in those patients that have Hunner's lesions, and we're going to diagnose them on narrowband imaging, which tells you where the ulcers are basically, and the lesions. And we're going to see before and after symptom severity after the injection of steroids.
So we don't know yet which is better, whether the burning or fulguration of the Hunner's lesions or injection of steroids is better.
We have no idea at this time, but in my own mind, injection of an anti-inflammatory agent like a steroid seems a lot less invasive than lasering or burning.
And last question, Dr. Whitmore, what do you foresee a new treatment for the future?
Well, I think we're understanding some of the immunosuppressants that the rheumatologists used will go forward in patients with very refractory illnesses. I think our understanding of neuromodulation is in its infancy, and I think we'll have better and more local therapies in the future. Our study of intravesical agents will probably improve in finding agents that will dissolve slowly in the bladder, so the patients can have a more topical kind of therapy.
Well, thank you so much, Dr. Whitmore, and thank you for your leadership in moving IC treatment forward.
Most welcome.